I'm Sophie Gatenby. I'm one of the members of the leadership team for the Community of Practice. We're really grateful you've all come this afternoon now, some of you morning, depending on where you are across the country. We are here to discuss a number of issues or a number of presentations today. But first, I'd like to acknowledge the traditional owners of the land on which we meet. For me today, that's the Bunurong tribe of the Kulin Nation. I offer respects to the elders of these traditional lands and through them all Aboriginal and Torres Strait Islanders people. For you who are new, our community of practice is organised by representatives from each state who are ethics and governance professionals, and we've just broadened the scope of the group to include governance professionals as well. This community aims to connect people across the sector to share ideas, knowledge and resources related to human research ethics committees and research governance. So without further ado, I'd like to introduce Michael Kios. Michael is our first speaker today, and he's a research governance manager from Monash Health here in Melbourne. Michael brings a wealth of expertise from across the university and corporate and hospital sectors. He's going to give us a talk about indemnities in ethics and governance. And so I will hand over to you, Michael. Thank you.
Thanks, Sophie, and welcome everyone to this session where I shall be presenting on indemnities, their purpose and the activities undertaken that may give rise to indemnification requirements. Compared to the science that most of you are conducting, this talk is on the lower end of the excitement scale, but is an integral part of research. The extent of protection that indemnities may provide to an organisation is dependent upon the risk of the research undertaken, the manner in which it's undertaken, and the parties that are engaged. Now, in conducting the research, as scientists, you collaborate not just with colleagues in your own institutions, but also with like-minded researchers in other institutions. This involves the transfer of data, biological samples and investigational product. So when conducting human research, it is obvious that ethics and governance approvals are required, but when collaborations with other parties are envisaged, some form of research collaboration agreement is also required. Now, when I say some sort of collaboration agreement, it can be a number of forms. For example, a clinical trial research agreement, research collaboration agreements, and a variety of others. Now, some of these agreements have indemnity clauses. Some have some sort of protection clauses that just fall short of being indemnities, and in specific circumstances, indemnities can be standalone documents. So what is an indemnity? It essentially is a contractual arrangement between two or more parties whereby at least one of the parties, that's the indemnifying party, agrees to cover a loss arising from an event that happens to another party, which is the indemnified party. In an indemnity, the indemnifying party may need to compensate the indemnified party for a number of reasons. These may include breach of contract or legal action taken by a third party. The liability of the claim therefore rests with the indemnifying party. This, however, can be dependent upon the limitations that may be specified within the indemnity itself. Indemnities can be wide-ranging or quite restrictive, dependent on the role of each party involved in the collaboration. Indemnities can be either one way or both ways, where the parties indemnify each other. In these circumstances, the restrictions are similar and confined to certain events or restricted to the negligence of the party breaching the contract. It is very rare that an indemnification clause is enacted upon. Actually, in my 11 years at Monash Health, I have not come across a situation where an indemnification clause in a research agreement has actually been enacted upon. So even though it might be very rare for an indemnification clause to be enacted upon, it could be dynamite. So why are indemnities required? In short, they may or may not be, depending on the circumstances. In regard to commercially sponsored clinical trials, it is a must. In research, when we talk about the indemnities, We generally associate these with commercially sponsored clinical trials, and there are 2 indemnity documents that are required by institutions. One for HREC approval, that's the one on the left, and one for governance approval, that's the one on the right, the standard indemnity. The HREC review-only form of indemnity is for when the sponsor provides indemnity to the institutional HREC for HREC review of a clinical trial. The other is the standard form of indemnity where the sponsor provides indemnity to the institution conducting the trial. So why do clinical trial sites require indemnities and insurance? As just mentioned, indemnities are signed to protect the HREC or the trial site. However, insurance plays a large role in this. When conducting clinical trials for a commercial sponsor, ethical review of the study is required. The ethical review is based on information provided by the commercial sponsor. Not only that, but there is also an unapproved drug or device involved in the trial, so the Ethics Committee evaluates the trial for its ethical acceptability, particularly the risk-benefit ratio for the approval of the study. Now, an Ethics Committee can only provide judgment on the information it has received, but in the event the drug or device causes debilitating side effects to a patient, the patient may take legal action against the Ethics Committee. The Ethics Committee is not the producer of the drug or device. It evaluates the ethical suitability for the trial to proceed. However, this does not prevent a patient who has suffered harm from the trial to take legal action against the Ethics Committee claiming negligence in review. This would cause a huge impost on the Ethics Committee and the institution if a claim were made, particularly when the drug or device is not even theirs. So this is why the HREC form of indemnity is important, as it transfers any liability from patient action from the Ethics Committee and therefore institution to the commercial sponsor. Of course, once ethical approval has been provided for commencement of the trial, the institution, represented by the institutional principal investigator, conducts the study. Again, if a patient is harmed by the sponsor's drug or device, the patient may take legal action against the principal investigator or institution. So this is where the standard form of indemnity protects the institution or principal investigator as liability is transferred to the commercial sponsor. However, it is worthwhile noting that in the event legal action is taken and the sponsor takes responsibility for the action, any damages that may be paid to the patient are most likely to be paid by the sponsor's insurer. That is why, as part of the institution's governance process, the institution requires a valid insurance certificate covering the sponsor, local sponsor or organisation that they may be representing. In essence, even though in the event of a legal action where liability is transferred from institution to sponsor, the sponsor is covered for any legal action imposed on it by taking out clinical trials insurance. Now, each institution also takes out different types of insurance policies, as action by a patient may not necessarily be the commercial sponsor's fault. I've earlier shown the front page of the Medicines Australia indemnity templates, but the Medical Technology Association of Australia also has similar HREC and standard indemnities on its website for device trials. I'll now go a bit more specific about the HREC review form of indemnity and the standard form of indemnity. You'll see that there are specific instructions on when to use each type of indemnity. This can be quite confusing or ambiguous in its interpretation, particularly when taking into account the notes. A simple unambiguous case is when your site is the only site and the HREC is under your institution. In this circumstance, only the standard indemnity is required. Having said that, most institutions still receive both forms of indemnity, which is fine, as HREC approval is often provided prior to site-specific authorisation. Another ambiguous case is when your institution is the HREC and is reviewing for one or more external sites, not your site. This is clear. The HREC receives an HREC indemnity and the participating institutions receive a standard indemnity. Now, this is the ambiguous case, and it may or may not be a problem. Usually it's not, but sometimes it is. Your institution is the HREC and is reviewing for more than one external site. Therefore, this is a multi-centre clinical study, but the HREC site is also participating. Now, there is no issue if the sponsor provides an HREC review-only indemnity listing all participating sites and a separate standard form of indemnity to all participating sites. However, a sponsor may refuse to add participating sites to the HREC indemnity based on the HREC review-only indemnity note that states, now I quote, "There is a different form of indemnity for use where the indemnified party is providing premises for the conduct of the study and HREC review, or is providing premises only." According to the note, it essentially states that the standard indemnity suffices. I've found that the problem is not with the provision of the HREC indemnity itself. The issue seems to be with the sponsor, including the participating sites on the HREC review-only indemnity. Although this is a very rare occurrence, I only had it happen to me maybe 5 to 10 times. My advice is, in this scenario, is to insist on an HREC review-only indemnity listing all participating sites, whether your site's participating or not. I now just want to go briefly through some of the clauses that place requirements on the investigator and institution to make the indemnity valid. Firstly, the legal entity name. Make sure the details on the front page are correct, including the HREC or institution details. That is the correct legal entity name, not the site, the correct legal entity address, and not the site address, and of course the correct ABM. It's the legal entity that is being indemnified. Now, in regard to approvals, make sure you have all the necessary approvals to conduct the study for this indemnity to be valid. Critical terms for the indemnity to be valid are that the indemnified party will obtain all necessary approvals to be able to conduct the study. That is also where, in addition to the indemnified party details, the principal investigators representing the institutions are listed on the standard form of indemnity, and for the HREC indemnity, the principal investigators and external sites are listed as being indemnified. So if you have a change in principal investigator or new sites added, dependent on which indemnity is being used, it would be prudent to update it. Now, participation, these clauses in the indemnity just connect participation by the HREC or institution in the study. In essence, they are stating the obvious but need to be included. Now, coverage of indemnities, a bit wordy on these slides, sorry about that. These are essentially the critical clauses whereby the sponsor agrees to indemnify the institution and affiliated personnel, such as employees and advisors, against any claims made by any clinical trial participants or their families for personal injury, including death, due to the investigational product. However, you'll note that at the end of each section, the indemnity has limitations whereby any action taken by the participants or their families is, quote, arising out of or relating to the administration and or use of the products under investigation or any clinical intervention or procedure provided for or required by the protocol to which the participants would not have been exposed but for the participation of the participants in the study. You can see that this does not include negligence by the investigators or the institutions. Institutions take out insurance coverage to cover for some of these circumstances. And of course, there's always these disclaimers. You will note that there are a number of disclaimers within the indemnities. Examples are negligence by the indemnified party, including failure to abide by the protocol. So obviously make sure you abide by the protocol. Complete control of any claim is transferred to the sponsor. This relates to the situation where there is a claim on the institution and the sponsor requires complete control of this to be transferred to them. And then you've got the institution does not make any admissions or takes action itself with written consent of the sponsor. Now, the CTRA, Clinical Trial Research Agreement, plays a large part in the indemnification process. Whether it be a clinical trial research agreement or a clinical investigation research agreement, there are clauses within these agreements that specify the requirements for indemnification. But they also outline the associated requirements, including compensation for participants and insurance by including schedules in these agreements. So, for example, Clause 5.8 refers to the indemnities and is related to Schedule 3 of the agreement, whereby the sponsor agrees to execute the appropriate indemnities. Clause 5.9 refers to the compensation for injury guidelines, which can be accessed via Schedule 5 of the agreement. And Clause 5.10 refers to the insurance arrangements, where Schedule 4 includes the insurance certificate. Just take note that for Phase 4 clinical trials, which are usually post-market trials used for potential marketing purposes, a separate standard form of indemnity is not required, as the indemnity clause is embedded within the CTRA. As it is generally for products already in the market, the indemnity is quite limited to negligent or wrongful act or omissions of the sponsor, or for breach of privacy laws by the sponsor, and specifically excludes negligent or wrongful acts or omissions by the institution. Now, of course, every study is not a commercially sponsored clinical trial. However, agreements must be in place between collaborating institutions. A common example is when a study is led by a collaborative or cooperative research group. In this circumstance, Medicines Australia and the MTAA have their CRG CTRA templates. In these templates, indemnities are not required. Liability insurance clauses take their place. The liability insurance clauses essentially specify that each party is liable for its acts and omissions in relation to the conduct of the study, and that each party must have enough insurance to provide indemnity to itself in case of legal action. Of course, you will all be aware that the Medicines Australia and MTAA agreements are not the be-all and end-all of collaborative clinical research agreements. We have research collaboration agreements, material transfer agreements, and a variety of others. Not only do we have these, but each institution has their own templates, some of which have, and others do not have, indemnity clauses. Provision of indemnities is an institutional decision and usually led by the institutional lawyers. However, it is also up to an institution to decide whether it will accept or not accept an indemnity. At Monash Health, I review nearly all agreements and indemnities for research. If an agreement passes my desk, the first thing I do is look for an indemnity clause, remove it and replace it with the clauses similar to the Medicines Australia CRG CTRA template wording on liability insurance. Now, with the risk of being bombarded by lawyers after this presentation, my advice to you is do the same. Replace the indemnity clause with the insurance and liability clause. A critical factor to look out for is when your insurer covers what your insurer covers, and this is especially relevant to indemnities. A number of institutions have exclusion criteria in their insurance coverage. One of the most critical that you should be aware of is the exclusion of USA or Canada. At Monash Health, when collaborating with the USA or Canada, we shall not accept an indemnity clause under any circumstance. Actually, we don't accept them from any international site, but I raise USA and Canada specifically here as a number of attendees to this presentation are likely employed by an institution that excludes USA and Canada from their insurance policy. My advice to attendees at this forum is you must be indemnified for any commercial study. This is just an extra one. In regard to private organisations, if you are providing HREC review for an investigator-initiated project, you should have an agreement in place where your HREC is indemnified for its review. Now, do not accept indemnities for collaborative research. If indemnities are a sticking point, have them amended to self-liability clauses rather than indemnities. Now, having said that, there are certain circumstances where you cannot get out of providing an indemnity. The classic examples are the NH&MRC or MRFF grants, where the Commonwealth Government requires indemnification if it is to provide funds, and any party listed on an MIA, that's a multi-institutional agreement, must provide similar indemnity to the coordinating site. At Monash Health, this is essentially the only circumstance where we shall provide an indemnity. What you also must be aware of is your institution's policies and delegation authority in regard to indemnities. For example, who is authorised to sign legal agreements and indemnities? If the institution is providing an indemnity, does it need to go through a particular process? These are all critical factors in your governance processes and compliance with legal institutional insurance requirements. As an example again, at Monash Health, only 2 people are authorised to sign off on research legal agreements, the Chief Medical Officer or Chief Executive. In regards to provision of an indemnity, it is only the Chief Executive. Now, for the Chief Executive to sign the agreement with the indemnity clause, the agreement must be legally reviewed and the legal team must determine that the indemnity is of very low risk. It then needs to be reviewed by the program director to agree with the low risk assessment. It then needs to be reviewed by the Chief Medical Officer and then sent to the Chief Executive for final approval or sign off. So to end this presentation, my bottom line is, for commercially sponsored studies, make sure you have indemnities in place. For non-commercial studies, avoid them like the plague and replace them with self-liability clauses. So on that note, it brings me to the end of the presentation and I welcome any questions. Thank you.
Thanks so much, Michael, for that fantastic presentation. It was very thorough. So we've had a question pop up in the chat. It's anonymous. It says, what about data and responsibilities clause?
Look, all of that still comes under the indemnity clause, because you can specify a whole stack of things as far as indemnification goes. So if any particular party has breached anything, because data is also included in the agreements. So if you make any breaches in regard to that, data is included in there.
Thanks, Michael. And I believe you've got another question in the chat from your colleague, Catherine. So she's written, hi, Michael, for a single site study where our organisation is providing HREC review and then SSA authorisation, some sponsors tell us that a HREC indemnity is not required because a standard indemnity, you sort of touched on this, will be provided with the SSA application. Does this mean our HREC members are not covered for the period between HREC approval being granted and the SSA application being submitted? What should we say to our
that is correct. Now, as I mentioned earlier in the presentation, I specifically raised this, and what I did mention was that SSA authorisation is often given after HREC approval. So in that time period, what you should do is insist on the sponsor to provide an HREC indemnity, and that was really what I was saying. Now, you're right, in between, there is no coverage. But what it comes down to is the site should not also start the trial until they've got site-specific authorisation anyway. So in reality, you're not going to be starting anything until you've got that. But really what it comes down to is, and I've had this happen to me a few times, you really force it upon the sponsor and say, and if they want to get tough, you get tough back with them and say, well, we're just going to hang on for site-specific authorisation unless you provide us the indemnity, because it's really an institutional thing. And to put it simply, the notes on the indemnities are quite confusing, and you know, they can be construed in different ways. But look, Catherine's right in that once you've given both, and quite often HREC and site-specific authorisation are given simultaneously, so you're covered. But if they're not, I would still keep on insisting on an HREC indemnity.
Can I just ask a question related to that, Michael? What would the HREC indemnity be covering for that period before the authorisation is provided? Like, it wouldn't be covering any of the work under the clinical trial because it wouldn't start. Is there a need to indemnify a decision before the trial starts?
I'll tell you what it covers is that quite often you will get sites where they get an investigator will get an HREC approval.
Oh,
and they sort of think, oh, I've forgotten to do the site-specific authorisation or the governance, so they've started the trial. So this is just a layer of protection in case something goes wrong.
Appreciating that. The other thing I'm thinking is, if we are ethically approving for another site and then our site as well, but we don't get HREC review indemnity, and then the other site goes ahead and starts before us, then our HREC isn't indemnified and something happens at that other site, could that also be a problem?
No, you should actually get the HREC
if it's multi-site, you'd always get your HREC indemnity.
Well, just get, that's what I was saying. And you know, there's been a few of those circumstances where I've had quite a few bun fights with some sponsors in regard to that, and generally they'll back down. But make sure you get that, because quite often you'll find that the sites, in regard to getting site-specific authorisation, one of the items they require for SSA is a copy of the HREC indemnity.
Yeah.
We have one more question in the chat. For phase 4 trials that don't require institutional indemnity, should a HREC still request a HREC only indemnity for the ethics review?
Yes.
Oh, we've got a few more.
Yes. For the HREC, yes, you do want, because the standard indemnities for the conduct of the trial, and they don't need a separate indemnity for the conduct of the trial because the indemnity is already embedded within the phase 4 CTRA. But you definitely need an HREC indemnity because that is before the contract is signed.
Can HREC institutions use indemnity forms for other types of studies that are not clinical trials?
Yes, we have. So if both parties are agreeable to it, yes, you can. Quite often what we use, as I mentioned before about private sites, we have an HREC agreement, but yes, definitely you can use that. And we even, believe it or not, we even have used it for non-interventional studies, even though it really refers to an investigational product.
You can't be too careful. Can sponsors request changes to the terms/clauses in the indemnity form?
We do not allow it. I mean, if you both agree, you're taking a big risk, and because obviously when it comes to agreements, either party can agree to those, and that's just like when you have, say, the CTRAs and you got the Schedule 7, and there's 4 million pages of different changes that sponsors have made. Yes, if you agree to it, you can, but my recommendation is no.
Yeah, try and keep it simple. Don't open that can of worms. Yes. So we're running pretty well to time. We have a couple more minutes for questions if anyone's got any other burning questions, or if I've missed any on the chat.
You made that really interesting, Michael. I really appreciated it. So thank you.
Thanks for having me.
All right. So no other questions. We might be ahead of time then. But there's another one. Yes, another one here. Where is the best to find an indemnity for a non-clinical trial project?
What I would suggest is set up an agreement. If it's a non-clinical trial, just include in it. But generally, what it comes down to is whether it's commercially sponsored or not. Because what I'm saying is, if it's a commercially sponsored study, you're using the Medicines Australia. But if it's not commercially sponsored, what I'm basically saying is don't have an indemnity. So, use the self-liability clauses rather than the indemnity. Now, if it is a commercial sponsor and it's a non-interventional study, still insist on the Medicines Australia one.
Another question that popped up in the chat. Can we please have a Medicines Australia collaborative agreement for non-clinical trials?
Well, it's funny you should say that, because at the moment, at the start of this year or last year, we had the Australia-wide collaboration agreement, which is now being used all over Australia. And in that agreement itself, it essentially has the CRG clauses for self liability. And I think I was one of the instigators of removing the indemnity clauses from that, and also one which is currently under review for Victoria, which is for the Victorian Translation Centres. That's another one which will be used in Victoria. But there is this agreement which is now Australia-wide and I believe available on the web.
Fantastic. Lincoln's also added all private sites. So is that similar to the non-clinical trial projects?
Yeah, look, because what it comes down to is, a lot of us are government bodies and we're sort of backed by the government. But when you've got a private site in there, in a way, you've got to think of it like a commercial sponsor. But the thing with private sites is they're not doing anything which might be as risky as using an interventional drug. All you just need to do is have an agreement with them where they're agreeing to abiding by the HREC review of the institution, and they will indemnify the institution for that. So that's what I'm talking about in regard to having a private site come in and having your HREC indemnified by the private site, just like a commercial sponsor would indemnify the HREC. Now, in regard to, say, a collaboration agreement, you'd have to decide whether you want them to indemnify you, but a lot of that depends on what is actually within the agreement itself, because sometimes we'll want it and quite often we don't. It just depends on what's involved in the actual project.
Thank you, Michael.
I was just going to say, we might actually leave any more questions for Michael. If you pop them in the chat, I'll get Michael to address them so people can see them. But we might let Courtney introduce our next speaker. And again, thanks so much, Michael.
Okay, like I said, thanks for having me.
Thank you. So our next speaker is Dr. Bernadette Aliprandi-Costa. Bernadette is the Technical Director, Clinical Trials Policy Section of the Australian Government Department of Health and Aged Care. So Bernadette's going to speak to us today. She'll be providing an update on the National One-Stop Shop for Clinical Trials and Health-Related Human Research. Thanks so much, Bernadette. We got Bernadette.
You do. Can I just check, are you able to see my screen?
Yes,
yes. You are?
It might just need to go into presentation.
Yeah. It's always a bit tricky for us with Zoom. You're never just too sure. All right, how's that? Can you see that?
Yes, we can see.
Okay, cool. Alrighty. Look, thanks so much for the opportunity to speak with you today. And thank you, Michael. That was an excellent presentation. In fact, I think we might invite you to speak at some of the Intergovernmental Policy Reform Group meetings. I'd like to give you an update on the project that the department is delivering on behalf of all state and territories via the Intergovernmental Policy Reform Group. And that is to develop a quality standard and accreditation scheme for ethics committees and their establishing institutions. See, this is the clincher. I can't move my slides. Let me just go out of presentation mode, sorry. Oh, can you see that?
We can't see your screen.
No. So I think what I might have to do, if it's in presentation mode, it won't move through with Zoom. It's just because of the high levels of security in our environment. So let me have another go, and I will leave it like this, but I think it should be big enough. Alrighty. So I'm just going to move this. Can you still see that?
We've now gone to your calendar.
Oh, okay. Sorry, well, it's picked it up off something else. Good. Okay. Alrighty. Well, look, thanks for the opportunity to give you this update. I will be brief. I know that we are running short of time now. So this project is being delivered by the department on behalf of the IGPRG, which is a cross-jurisdictional group that has been delivering a number of initiatives on behalf of all state and territory governments for over a decade. Its latest iteration is the IGPRG. Professor Ian Chubb is the chair of that group, and he has really now been charged with leading and implementing a number of the reforms. The first being, which I'm sure you're very familiar with, the quality standard for clinical trial services. And while it's not yet embedded under the ASQA scheme, sites are beginning to be assessed against a maturity scale. Another piece of work is the one-stop shop, for which we received some funding through the last budget to drive through some technical work to really finalise the outcome of that project. So this project will deliver a single national approval system for all health and medical research. So it will enable the approvals of all research, enable the concurrent SSA process, facilitate the business processes of the TGA and the OGTR, and then it will provide a research management system at the level of the trial site. We have just brought back under the auspice of the department the project to develop this quality standard for ethics committees. And then, of course, we're also working on updating the guidance for teletrials and clinical trial services. I'm going to jump to the aims of the project, which is to develop a quality standard and a scheme that will enhance the consistency and efficiency of the review process and build reciprocal confidence in the ethical review process. So that's really the problem statement. We know that while the NMA has been a key enabler of cross-jurisdictional, of the acceptance of cross-jurisdictional ethical review, we know that there have been some barriers to the acceptance of review, either because an institution or a jurisdiction is not satisfied that their relevant legislation has been adequately taken into account. And so we anticipate that by developing a national quality standard and an accreditation scheme, it's anticipated that we will move towards a small number of highly skilled committees that are well supported by their establishing institutions, that will have the skills and education required of them to improve the acceptability of their reviews across jurisdictional borders. So there has been a little bit of a gap in the deliverables under this project. It was initially being delivered by the Australian Commission on Safety and Quality in Healthcare. We began there by undertaking a literature review, which is now publicly available. We then mapped all the standards that we found across the international literature. We mapped them against the national statement. And then we drafted the very first version of the quality standard for ethics committees and their institutions. We then sought endorsement at that jurisdictional level through the then CTPRG, now the IGPRG, and we took it to targeted consultations. So we had involved in that process ethics committee secretariats, research governance officers, clinicians, industry, the university sector and consumers, as well as Aboriginal and Torres Strait Islander ethics committees. And we generated a report which we've now got endorsement through our IGPRG. We brought the project back into the auspice of the department only in June of this year. We re-established our Ethics Committee Advisory Group. The membership of that group is on the department's website. And now we're moving forward with the next phase of work. So with feedback from the IGPRG and our advisory group, we've also looked at the changes in scope. So we know that people feel very strongly that a quality standard and accreditation scheme shouldn't be limited to the small number of ethics committees currently operating under the NMA scheme. We heard quite strongly through the targeted consultations that there was a real need to move beyond that limited scope. So we've taken a summary of the feedback from the consultations back to the IGPRG, and essentially these are just some high-level features of that feedback. But when we asked participants in the consultation, what did they see as features of a high-quality ethics review? They said decisions that are made with close reference to the national statement, decisions where there was adequate discussion on the relevant issues, and there was evidence of that in that review. The scientific review was highly relevant to the application, and there were sufficient experts to undertake that review, and that the review was consistent with existing local jurisdictional policies. Other features of a high quality ethics committee itself, participants said they considered ethics committee decision making was independent of its institution. So even though we know an ethics committee doesn't exist in the ether, it has to be supported by a legal entity. So we're, in this sense, it's an institution. In the public sector, it's a public sector institution. In the private, it's a legal entity. Where conflicts of interests have been appropriately identified and managed, and there's evidence of that. Where the ethics committee uses the full range of decisions available to it. So they will approve, reject, amend, or refer on if they don't have the expertise. So an ethics committee that just approves everything that they see, and we did hear that through the consultations, that individuals were aware of where they could get a quick review. So an effective or a high quality committee was one where they were really reviewing or rejecting or amending projects as appropriate. When the committee could identify that it lacked the appropriate expertise to undertake a review, and that they would then seek an alternate or external review. In terms of feedback about the scope of the quality standards in the accreditation scheme, participants in that targeted process felt that both the ethics committee and its host institution should be accredited. So we wouldn't be seeking to accredit a committee alone. That the committee and the institution should aim for a set of standards that were accessible to all committees. So it should be that all committees were aiming to meet a minimum national quality standard. And other considerations were that we actually sought requests from Commonwealth agencies to expand the development and the quality standard and accreditation scheme beyond the NMA. And when you work that through, we have over 250 or 260 ethics committees in this country. 115 of those are certified, and 35 of those ethics committees are currently operating under the NMA scheme. And so there's only a relatively few trials that are actually reviewed under that scheme. So there's great benefits to the sector if we're able to expand the accreditation scheme beyond those committees currently operating within the NMA. The aim of considering what would a future accreditation scheme look like, we want to develop a quality standard and a single national accreditation scheme for all committees reviewing health and medical research in Australia, and enable the accreditation of their host institutions. Ultimately, we're aiming for the highest standards of integrity and ethics and scientific review. So that's the aim of this work, and therefore it should be open to all ethics committees across the country. We will be taking options back to the sector around what a future accreditation scheme looks like. We haven't landed the scheme. We want to test with the sector what it could look like. But when we look internationally, what we have seen is that some of them operate via an opt-in approach, and that is really similar to the certification scheme, where they opt in and then they do a self-assessment against the certification scheme. It could also be embedded into an existing health and human services accreditation scheme. So if you look at Research or Standards Australia, it could be that we align with a national health and human services accreditation scheme. It could be extended to ethics committees and their host institutions across the public, private and not-for-profit and university sectors. We were thinking that that would be a future approach, but we heard through our targeted consultations that people would like us to test how it would operate in a not-for-profit and university sector as well, because of the crossover between the health and medical and university sector. Whether it should include ethics committees in their institutions that review and oversee single site as well as multi-site research, or whether or not we should restrict it to multi-site research. And whether institutions providing training for researchers and or assisting them in preparing their applications should also be part of the scheme. Certainly, we would be integrating the operations of the scheme and the reporting into the National One-Stop Shop. Similarly, when we looked across the international literature, we also saw that some schemes operated, and the US scheme operates by periodically doing some on-site visits to assess compliance. We do have models of where there is a self-assessment or there are supplementary requirements seeking accreditation of ethics committees in specialised areas. So this is where we were thinking about models whereby if you had a small number of ethics committees, would it be a small number of secretariats that could access a pool of assessors, so the skill set that they required? Would it be that we would need specialist ethics committees or standalone, say in paediatric health and medical research, just as we have in justice health? So what would the models of operation look like? Certainly, we heard very clearly that there needs to be the provision of training for ethics committee members, and not only in the national statement and in the quality standards, but also in cultural safety. And that training should be extended not only to the committees, but also to the host institutions. And what we know about cultural safety is that it isn't the institution's view of cultural safety, but rather it's a measure of the participant and how culturally safe they feel when they participate in research. Insurance indemnity arrangements would have to be clarified under a new quality standard and accreditation scheme. And we heard really strong support for the remuneration of ethics committee members, which we know there are models of in the not-for-profit and private sector, but not so much in the public sector. And whether there was a potential requirement for that research that is publicly funded to be reviewed by an accredited committee that is hosted by an accredited institution, and whether that would be effective in streamlining the review and approval process. So I know we only have 10 minutes left. The literature review, so the really the leading countries that have some form of ethics committee quality standard and accreditation process were found predominantly in the US, Canada, and in the UK. And that literature review is accessible online, so I won't touch on that. But they do have different models of operation. And so as we come forward with proposed models for implementation, you might want to reflect on that literature review and bring those insights to us as part of that national consultation. We know that accreditation isn't always viewed as the panacea. We heard that through our consultations. We want to make sure that if we were developing a scheme, that it wasn't seen simply as a tick box exercise, that there was genuine engagement by the host institution, that there was genuine support for the establishment of the committee. We want to make sure that it's a mix of assessment of the process as well as observation around the operations of the committee. So often there is that excessive focus on the assessment of the committee's structure and processes, SOPs and documentation, rather than examining the quality of the deliberations of the committee. So there needs to be clearly supported ethics committees by their institutions and an ongoing commitment to quality improvement and sharing the findings of committees. And we heard of that preference for workshops with ethics committee members, whereby there would be a shared review of a particular project that then could be tested and shared within a group setting. In terms of the participant experience and community expectations, we really wanted to understand from the sector to what extent does the ethics review really protect the rights and interests of participants in their communities? What do they hope to obtain from the ethics committee review itself? And how could their perspectives be incorporated into a future accreditation scheme? So these are all things that we will be testing with the sector as we move forward with the consultation. So there really are a number of topics that we want to test with the sector, and I've got a high-level overview here. Did you want me to run through them, or would you like me to pause and answer any questions about the project?
We only have one comment so far, Bernadette. So if you've probably got another 3 minutes if you wanted to wrap up.
All right. Okay. So in terms of what we would like to take to the sector is we're going to ask questions around what additional features of a high quality ethics review should we consider when we're developing the standard. So as part of the consultation, you will be able to see the quality standard that's been drafted so far and tested through that consultation process. We'll also be asking what other features of a high quality ethics committee have we not identified. So when you do see that standard and the resources around it, what have we missed? We're also going to ask you what a national accreditation scheme should look like. We don't want to limit it to any existing scheme that's currently in place in our operating environment. So what would a national scheme look like? And this is where that broader scope across the health sector, aligning with national and international standards. So really looking at research standards at a national and international level, making sure that we're aligning with that. Although we've had really strong feedback that we have to very heavily reference the national statement and align very closely with that, and that is what we've done. And then ultimately, is accreditation enough to build trust and confidence in mutual acceptance? So if we can demonstrate that the Ethics Committee review has taken into account the specific legislation in each jurisdiction that's relevant to the particular project that's being undertaken, could we really move towards one ethical review for a multi-centre clinical trial and have that accepted across the country? And that's a really important question, because we know that that is what the European Union is working towards. They've implemented their new clinical trial information management system. They are working towards one review for the entire European Union and concurrent authorisation within each member state. And they're aiming to get those reviews up in 4 to 6 weeks. So for Australia, it would be a game changer if we could move towards a quality standard that built assurance across the sector that this review would be acceptable across jurisdictional borders. That is not to say we would accept a review from another country, but we do want to make ourselves competitive. And so being able to have one review for multi-centre research would really streamline that process in this country. So I'm going to pause there.
Thank you, Bernadette. Thank you for your presentation. We have one comment that's popped up, and that's just generally about the one-stop shop. If RGOs could please be able to access the submitted documents that are provided to the HREC, so that
Oh,
there's...
yes. So I think we did demonstrate that when we built the proof of concept back in 2022. We built it to demonstrate that all participants in the review related to that particular project, so the researcher, the applicant, whether it's a commercial trial sponsor, the ethics committee secretariat, and the research governance officers have access to all of the materials. They have visibility of the review and approval process, and those documents are shared. And if there's feedback from one institution around authorisation, that they can also access that. So they're not asking the same questions of the sponsor to enable their authorisation. They're able to see the feedback from other institutions. So we tested that with the sector as part of the development of that proof of concept. And of course, some of you may be participating in the review that the technical team are doing now to sort of really specify and bed down what those data fields will look like. I know the core elements of the SSA have been agreed, they're publicly available, they'll be built in. And just touching back to Michael's presentation, we are working towards that concurrent risk assessment at the local site level to be undertaken concurrently with the ethical review, so that once the ethical review comes in, authorisation can be recommended. Obviously, all the other documents, contracts, indemnities are in place, and the site can sign off. So that sequential process is not what we're proposing.
Okay, thank you. We are running, we only have a couple of minutes left. We have one last question, which is just about whether this HREC accreditation scheme will extend to HRECs that are reviewing non-health and medical research as well. Is that the plan?
Well, that was tested with the sector and in the first instance, and we did speak to a number of universities, but we do want to expand through the public consultations to really test that concept with universities. So we know that currently an approval that's undertaken in the public health sector is generally accepted by the university sector. It's vice versa, it's not the same. So enabling universities to participate is something that we've heard some support for. But of course, universities do a whole lot of other types of research, animal research and education and social science research. So we do want to facilitate that, but we will test that through the public consultations.
Great, thank you. Thank you so much for your time, Bernadette.
It's a pleasure.
And thank you for everyone who's come today and attended. Our next Community of Practice event will be on the 29th of November. You can register for the on the link in the chat. And the best way to engage and communicate with each other in our community is through our Microsoft Office Teams group. So if you would like access to the group or you have any direct questions for our leadership group, you're very welcome to reach out to myself or Sophie. I'm going to put our emails here so you can flick us a note if you have any questions or if you don't have access to the Teams group and you'd like to be added. So on that note, thank you very, very much for our presenters, Michael and Bernadette, and thanks to everyone else for coming along today, and we'll see you next time.